you hear a dermatologist talking to a patient called Nigel Macness. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mr. Macness, I have your notes here, but perhaps you could tell me in your own words how the condition developed, the treatment you've had, and anything else you think I should know.
Sure. Well, I've got these skin problems which seem to be getting worse. At first, I thought I had dermatitis or maybe even a fungal infection. I'd had something like that as a child. Then I started noticing these thick red areas on my skin. They're sort of a little raised, I guess. They just got worse, and the affected area got bigger and bigger all the time. I was a bit worried that it might be contagious, you know. I was worried I'd picked up something from one of my young nieces. I see them quite a lot.
And these patches are...
They're mainly on the outside of my elbow and over my kneecaps. Oh, and on my neck.
Right.
I've been wearing long-sleeved shirts and jeans to cover them up, but I can't hide those, so everyone can see them. They're also very painful. Sometimes it feels as if my skin's burning. It's very itchy as well. I try not to scratch it, but it's almost impossible, especially at night. Sometimes it's so bad that I find it hard to get comfortable and I can't sleep. It leaves me tired most of the time, and that has an impact on my work during the day, quite apart from the embarrassment of the symptoms themselves. I'm a tour guide, you see, so I'm very much in the public eye.
Yes, I imagine that it's been difficult for you. Have you tried taking anything?
Well, I tried to fix the problem myself at first. I bought some cream from the pharmacy to see if that would help. Sorry, I can't remember what it was called.
That's okay.
It didn't do any good anyway. So I tried a non-allergenic soap, but that didn't make any difference either. I just want to get something which will clear this up.
Yes, I understand. Are there any other health issues I should know about? Maybe when you were a child?
Not really. I used to get acne as a teenager, but no worse than anybody else, and it cleared up by itself, really. At the time, you're very aware of these things, aren't you? But I haven't had any other problems like that. But there was something else that I didn't tell my GP about. I'd forgotten about it because I hadn't been to see her about it. I went away on holiday with a friend the summer before last, and we managed to pick up scabies from one of the cheap hostels we stayed in.
Right.
I was covered in a rash. It was extremely irritating at night. Now I think about it, it was all over my body, especially around my midriff. It looked like I was covered in little pimples. Fortunately, we got rid of it using a lotion from the pharmacy, but I never mentioned it to my doctor.
I see. And any other health problems?
Oh, I did have a bladder infection a while ago, last year I think, but I haven't had any problems since then. Do you think that could have caused my current problem?
I shouldn't think so. You're probably aware that this is quite common, and I noticed that your GP sent away a urine sample for testing before referring you to me. The results are quite normal, so I wouldn't be concerned at all.
Well, that's something, I suppose.
Okay, well, as you say, it's different from your current symptoms. What about the effect your current problem is having on your general mood?
I'm just sick of dealing with this. It's really knocked my self-confidence a lot and affected my body image so that I don't go out much anymore. I have to go out to work, obviously, but I sort of keep away from people as much as I can. I think because everyone can see I've got a problem, it's stopped me from doing things like playing sport or swimming. I feel lonely most of the time and a bit depressed, if I'm honest. I'm also concerned that I haven't started any treatment at all. I'm hoping that it's not too late now.
I can appreciate your concerns. Now, what I'd like to do is give you a skin biopsy as soon as possible to see exactly what's going on. I think we can book you in for that early next week. Once we get the results, I'll be able to get you started on some...
For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mr. Murray, I'm Dr. Corbett.
Nice to meet you.
Yes, sir. Nice to meet you. Yeah, first time we've met.
Yes.
Yeah.
Yes.
So I understand you made an appointment for an examination.
Yes, correct.
And we're going to, a complete physical examination, I understand.
Yes.
And I'm going to ask you about why you came into that, but will you mind if I take a few notes just in case?
No, that'd be fine.
In case you got lots to tell me.
Yeah.
Don't want to miss too much.
That'll be fine.
Good, good. So you made the appointment for an exam. When's the last time you had a physical examination?
Probably 2 years ago.
2 years ago.
Yeah.
Okay. Well, tell me why you made this one.
Well, I had these chronic headaches going on that I've had for about 3 months now, and they're just not getting any better, and I want to see if there's something we can do about it.
So when you say chronic, you're referring to the fact that they've just been steady for 3 months, or they've been longer than that?
Well, it started 3 months ago, and they're like every other day or so, and now I'm having them every day. And
so you have no days when you don't have a headache?
I have a headache every day.
But at the beginning, it didn't seem to be quite as noticeable then for you.
No.
Describe the headaches. Where are they, and what do they feel like?
They start at the back of my head here, and they kind of come up around my temples, I guess you call it, and into the front of my head. Sometimes they're throbbing. Other times they're not quite as bad.
Yeah. So it's both sides of your...
Yes.
It starts in the back and comes up the front.
Correct.
Do you have a headache all the time, or does it just come in episodes?
Well, I have a headache all the time until I take something. I take Advil and Tylenol that seem to help it, and that eases it up.
Is it ever gone? Is it always something there?
There's always something there. I always know it's there. It's just the intensity of it.
I see. Can you tell me a little bit more about what you notice? For example, when is it the worst? At night, in the morning? Or does it make a difference?
Well, it doesn't make a whole lot of difference. When I don't get enough sleep, it's really bad. If I move my head in a certain way, or if I strain or stretch my head in a certain way, it seems
Like
quite
what
worse.
way? Can you show me that?
If I go like, to the back, or if I'm bending over, just any exaggerated moves.
Any exaggerated move makes it
seems to make it worse. And if I don't take the Advil and the Tylenol, it seems to be worse.
I see. So this 3 months ago it started. It's both sides. It's in the back, and you can make it worse if you either extend or lean forward for too long.
Yes. I call them exaggerated head movements.
Yeah. What happens when you're lying down? Does that ease it or make it worse?
I think that eases it some.
It does.
Especially if I can get some sleep.
I see.
It seems to ease it up some.
So the act of lying down and sleeping doesn't make it worse?
No. I
Makes
would
it
say
better, maybe?
Yes.
I see. Does it change based on if you're eating, for example?
No. You know,
Does eating make it worse or better?
No, eating doesn't seem to
So having a full stomach
exacerbate it.
doesn't seem
No.
to bother at all here, huh? How about if you're concentrating, is when you're driving? Or reading?
No, it doesn't make it worse, except when it's really bad, I have a hard time focusing.
Okay, yeah, that's helpful. Yeah.
Yeah.
Does it ever seem to be more one side than the other?
No, it always seems to come up and be just, it kind of like meets in the middle.
Meets in the middle, huh? Starts in the back, goes around, meets in the middle.
Like a tight band.
Yep, yep, yep. And the part that's always there is what? In the back or all over?
I would say in the back.
In the back
Yeah.
too.
It always starts in the back. I got rear-ended in a car accident, and I can remember my neck got jerked, and I had a sore neck for a couple days, and then the headache started shortly after that.
So that accident started this thing off.
That's when it all
So
started.
you had no headache before this?
No, I had no
That's helpful.
previous headache.
So tell me about that. How fast were you? Were they going?
Well, it wasn't very fast. It was in a parking lot, and I was backing out, and somebody else was backing out the other way, and we met. And I just remember that jerk of my head
Gotcha.
and having a stiff, sore neck.
So both cars couldn't have been going more than startup.
Yeah.
Okay.
5 miles an hour or something like that.
Did you strike your head when that happened?
No.
That you recall?
Not that I recall.
Yeah.
I just remember it kind of being, I guess they call it whiplash.
Did you get out of the car right away?
No, I sat there for a few minutes, and then I got out of the
Did
car.
you?
It startled me.
Did you?
Yeah.
Then you said the headache started after that. How long after the actual accident did the headache start?
3 or 4 days after.
So it wasn't right away. There was a
Wasn't
little
right
bit of a
away,
warm-up.
yeah.
There was a kind of an interval in there where you felt
Yes.
fine. I see. Did you think that you had hurt yourself?
I didn't think I really had hurt myself. I didn't, I felt startled and, just kind of shaken, but I didn't feel like I was really injured.
But didn't. Okay.
I didn't go to the hospital or anything like that.
Yeah. Have you? And you said you take some things for it. What actually helps it? What do you?
Tylenol and Advil. I take, I guess it's,
How much do you take?
I take a lot. I take 16 Advils, 4 tabs, 4 times a day,
Wow.
and I take,
Self-prescribed?
yes, 2 Tylenols 4 times a day. So I'm taking
8 Tylenol and 16.
24 pills a day.
Wow. I take it you warmed up to that. That you weren't using.
Right. I started out with
I
less and it wasn't working, so I just
I
kept
see.
adding to it, and it does give me some relief.
It's a lot of medication.
It doesn't, yeah, it seems like too much. That's one
Is
of
that-
the reasons I came to see you.
Good for you. Yeah. Does that mean it just keeps getting worse?
The headaches just kept getting worse in the severity of them, yes.
Yeah. That's a lot of medication.
Yes.
Before you had this accident, did you use those medications much, if at all?
No, very seldom.
No, never had to take that kind of thing with
No.
any regularity?
No.
Okay, okay. I need to know, too, what else do you experience? Anything else? Does this make your body feel different or painful or uncomfortable in any way?
It makes you feel stressed. I feel stressful with it. I can't sleep well. It's uncomfortable.
Yeah.
It's just kind of a nagging thing that's there all the time.
Does it bother your shoulders, your arms? You feel anything down here?
No,
Strength,
pretty good.
tingling?
No, not
How
really.
about just being able to use your arms in normal motion?
Yeah,
That's not disturbed at all?
No, that's fine.
I see, I see. Wow, so you had an accident, took a couple of days for this thing to get to you, 3 or 4 days, but then it started bothering you and persist, and now almost has this stubborn worsening. Is that what I'm...
Daily.
Daily. What kind of work do you do?
I work in a car dealership. I'm a service manager.
Oh, yeah. So has this had an impact on your ability to just do your normal job?
Well, again, it has in that it's uncomfortable. I feel stressed because of it. I'm able to do my job. I like my
So you can
job.
do your work? Have you missed any days from work?
I think I missed 2 days in the beginning, but I've been at work since then. I'm able to go to work, but I make sure I have my Advil and Tylenol with me. Other than that, I'm
You
working
sound like a great
okay.
employee to me. To work through this kind of thing is pretty difficult.
Well, I like what I do. I work on vintage cars on the side.
I see. Yeah.
So I
Okay.
try to make it.
I have a sense of what you're telling me. What's your diagnosis?
I don't know if I did something to my spinal column back there. I don't know what you guys call it, but something happened when I got hit, is what I think. A jerk did something. Other than that, I don't know what it is.
But you're fairly sure there was a couple of days in there where it wasn't obvious to you that there was anything wrong?
Other than it just being sore.
Okay.
It was sore and stiff. But the headaches didn't start, like I said, until about 3 or 4 days later.
So there was some discomfort?
Yes,
right
there
away.
was.
But you would call it more soreness or stiffness?
Yes.
Than actual headache like you're
right,
having now? Okay.
Right.
Gotcha. Yeah. I need to know a few more things about the effect of this on you. How's your sleeping? Do you sleep okay?
I don't sleep well at all.
Why not?
The headache, the discomfort, it's hard to get to sleep. I sometimes can get to sleep and then the headache wakes me up. So my sleep patterns have been totally disrupted.
So how much sleep are you getting at night compared to what you'd like to get?
Well, I used to sleep the night through, which was probably at least 8 hours. And I'm probably up 3 and 4 times a night now.
Wow. And how long is that? I would call it a sleep deficit. How long has that been going on?
Well, this happened 3 months ago, probably 2.5 months now. Because it wasn't as bad in the beginning, but they did just get worse.
Did you consult with anybody else, or you've been just toughing this out on your own?
Just been toughing it out on my own and trying to, hoping it will go away, but it's just getting worse.
But you haven't been able to do your work, think, use your hands?
Yes.
Nothing disturbed in that way, huh?
No.
Gotcha. Anybody else know? Did your wife, are you married?
Yes, I am.
You've been talking to your wife about this?
She certainly knows.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Professor Lynn Fritschke is a cancer epidemiologist at Curtin University in Perth and chaired the subcommittee at the International Agency for Research on Cancer, which concluded just how carcinogenic Roundup and his stablemates are.
Now read the question.
That leave us? I mean, is the IARC going to change its mind now?
I don't think there's enough evidence to change the mind yet. I mean, a possible carcinogen is still the case. There is very strong mechanistic evidence that glyphosate can damage cells and damage DNA in animals and possibly in humans as well. And so there is, some evidence that it may be carcinogenic. So I think just having that other one big study doesn't necessarily negate the whole decision.
So where does that leave us with glyphosate for casual use or occupational use? Should it be banned?
I think that might be going a little bit far at the moment with the evidence we have. My personal opinion is that we should minimise it as much as possible, and wherever possible use things that are less toxic or less potentially toxic.
Question 26.
Dr. Diana Adams, a medical oncologist at MacArthur Cancer Therapy Centre, and the co-founder of Avexia Care.
Now read the question.
In all cancer types, there is a benefit to exercise. We now know that exercise can actually mitigate some of the side effects of therapy and can actually improve the quality of life for those patients both during and after therapy. In addition, it is possible for some cancers it may actually improve their chances of the cancer not returning. So we know that exercise can actually improve the patient's fatigue through therapy. It's likely to actually improve the chance of them completing their therapy. So the medicines we give to treat cancer can increase the chance of side effects and fatigue, and exercise can ameliorate these side effects. We know that it is safe, it's been proven in clinical trials, with actually quite significant volumes and intensities of exercise. A classic example would be prostate cancer, where we suppress testosterone. And we know that testosterone is important for muscle mass. So by using exercise, we can counteract some of the effects of that muscle loss through a tailored program.
Question 26.
Dr. Jules Montague is a neurologist from Dublin and author of Lost and Found, Memory, Identity, and Who We Become When We're No Longer Ourselves.
Now read the question.
Sure. So you would think that your most emotional memories would be the most accurate, but it transpires that's not the case. If you look at things like the Challenger disaster or 9/11 or Lockerbie, for example, plenty of studies have been done in some of these scenarios where people will impart memories, for example, as you said, in 9/11. And there was a study that looked at downtown participants, so people who were really close to what happened and some who were further away. And those who were involved and closer to the action of what happened that day actually had lots of memories to impart, and they were very vivid, but not necessarily more accurate. So they were able to fill in lots of information, but it wasn't necessarily accurate. We think that's because the way our memory works depends on how much emotion is in a situation. So if you're personally remembering something very emotional right now, the hippocampus, of course, is kicking in. That does memory. But so is the amygdala, which is all about emotional memories. And that means your memories certainly are more vivid, but it doesn't mean that they're more accurate. And again, it's not that you're lying in any way. It's that the circuitry in your brain, for evolutionary purposes, has decided to kick in a slightly different.
Question 28. You hear.
Dr. Charlene Wong, a paediatrician and health policy researcher at Duke University in Durham, North Carolina.
Now read the question.
And the study is to collect deep health data in a cohort of at least 10,000 people in the U.S. in an effort to map human health and health transitions.
And they know that they're being mapped?
They do. They are agreeing to be part of the study. Many of them have joined the study because they're actually very excited and altruistic in wanting to help map human health.
So this is what technically would be called a cohort study.
That's correct. It's a longitudinal cohort study.
So you're gathering a group of people together and you're following them through to see what happens to them. Why is Google involved? Are they picking up data from their behavior online to assist you, or are they just using Google to recruit?
Sort of all of the above, I would say. We are collecting a broad range of different types of data, from imaging studies to blood tests and urine tests and even tests on the stool to look at all the different molecular markers that are available currently. We are also eventually going to be looking at other types of data, including data from people's medical records, data from what they are doing online. This study is still evolving to determine what all the data points that we might be collecting will end up being.
Question 29. You hear
Dr. Claire Ashton-James is a senior lecturer at the University of Sydney and works at the Pain Management and Research Institute at Sydney's Royal North Shore Hospital.
Now read the question.
Okay.
Claire Ashton-James.
The important thing to realise about pain is that it's a subjective experience based on three main components. There's somatic input, so feelings of aversive sensations. There's an evaluation of those sensations, so how harmful or threatening are these sensations, which is subjective. And then there's also the emotional component, so how distressed am I in response to these aversive sensations. And the social context you're in when you experience pain has directly influences your evaluation of how harmful the sensation is, how potentially threatening it is to be in pain, to be injured in that situation, and very closely related to that is the amount of distress you feel in response to that aversive sensation.
So what are the implications for how we can better manage people who are in pain?
My research focuses on healthcare professionals and their role in patients' pain experience.
Question 30. You hear
A Health Minute with Dr. Norman Swan.
Now read the question.
I assume that given the choice, you'd rather age with your marbles intact, and there is evidence that lifestyle matters. But what about specifics like physical activity and diet? Particularly the Mediterranean diet, which is typified by a low proportion of land animal protein, lots of plant-based foods, olive oil as a source of fat, and a little wine. Two recent studies of people in their mid to late 70s help a little. One study followed people in New York for over 5 years, looking at the incidence of Alzheimer's disease, and found that exercise, particularly more vigorous exercise, reduced the risk of Alzheimer's, as did closely adhering to a Mediterranean dietary pattern. About 1 in 5 people with the lowest level of exercise and diet adherence developed Alzheimer's, compared to about 1 in 8 who were goody two-shoes, and that was after allowing for other differences between the groups. The second study, in France, looked at decline in thinking ability and the Mediterranean diet, and found a weaker link and no effect on the risk of dementia. It may be that in France the average person eats more of a Mediterranean diet than Americans to start with, making differences hard to find.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
As a physiotherapist of 22 years, I've been asked all sorts of questions, but the one I hear most often is, can physiotherapy help my condition? Physiotherapy assesses, diagnoses, treats, and prevents a wide range of health conditions and movement disorders. It helps reduce pain and repair damage while increasing mobility and improving quality of life. In some instances, it can be an effective replacement for surgical intervention. Obviously, not all conditions can be cured by physiotherapy alone, but help it can certainly do. So today, I'd like to focus on a condition that still creates controversy when mentioned alongside physiotherapy, and that is scoliosis. Can physiotherapy make an impact on someone suffering from this condition, in particular mild to moderate scoliosis? Let's find out. Scoliosis isn't always easy to treat, but understanding this condition and its related issues will help a physiotherapist determine the best possible options. A scoliotic spine has one or more curves to either side exceeding 10 degrees. It can resemble a C or an S shape. What makes it difficult to treat is that the majority of cases have no known cause. Two specific types are easier to deal with, however: structural scoliosis, which results from the development of the musculoskeletal system, and functional scoliosis, which occurs from muscle imbalances, leg length discrepancies, and inflammation of the tissues. These both have definite causes, allowing us to create an individualized and comprehensive treatment plan. Physiotherapy is but one part of the multidisciplinary network of healthcare professions employed in the treatment of scoliosis. A confirmed diagnosis comes firstly from a thorough physical examination for any abnormalities and asymmetry. If scoliosis is suspected, then an X-ray will be taken to confirm what's known as the patient's Cobb angle, or severity of the scoliosis. From here, physiotherapists work closely with doctors, including orthopedic spine specialists, in determining the best options going forward. I believe a good, multifaceted approach to this is ideally broken down into 4 distinct phases. The first of these, in my program, is pain relief. Although not all scoliosis sufferers will experience pain or even discomfort, many do, and for these patients, the provision of pain relief assists with compliance and also with corrective or prevention exercises. Physiotherapists have a variety of techniques for achieving this, such as the releasing of tight muscles through gentle massage, acupuncture, the use of supportive postural taping, and various electrotherapy modalities such as ultrasound. Phase 2 is a particularly important step for several reasons. It's for rectifying any imbalances through stretching and strengthening exercises. This often still includes taping techniques until strength and flexibility have increased. Physiotherapy here focuses on both sides of the spine as well as adjacent areas like the hip or shoulder, depending on what's impacting spinal alignment. The aim is to restore the range of motion of the spine, muscle length and strength, as well as endurance and core stability. This stage is paramount for allowing ongoing treatment in Phase 3 to occur. This is because it's there that the patient requires the strength and flexibility gained in Phase 2 in order to resume normal activities. These include sport and recreation, which is the objective most patients have in mind during the treatment process. It's where we aim to restore full function. This is where we, as physiotherapists, need to tailor rehabilitation to the specific patient so they can safely achieve their functional goals. This, of course, includes trained athletes who place great stress upon their bodies, so caution must be taken when giving advice, and strong encouragement is needed for keeping to realistic recovery times. The final phase is undoubtedly the most important in terms of full recovery, and this is the prevention of a recurrence. This relies heavily on the partnership between physiotherapist and patient. By this, I mean we identify the optimal exercises for the patient to continue, and it's then up to them to maintain these exercises throughout the course of their life. Here too, other professions may be utilised. For example, in a case of an unequal leg length, a podiatrist could address this with a heel rise, shoe rise, or built-up foot orthotic. What patients expect to achieve and what is achieved varies greatly. However, those with mild to moderate scoliosis who have a commitment to maintaining their newfound strength and flexibility can expect a full recovery, especially if diagnosed and treated early. Physiotherapy is a vital part of this recovery and prevention and should never be underestimated. So, the next time you're asked, can physiotherapy help my condition, I'd be inclined to give a firm nod and respond by saying, with your commitment, physiotherapy is invaluable.
Now, turn over and look at Extract 2, questions 37 to 42. You hear a clinical psychiatrist called Dr. Evelina Horton discuss treatment for agitated patients in an emergency setting. You now have 90 seconds to read questions 37 to 42.
everyone. My name is Dr. Evelina Horton, and in my presentation today I'd like to discuss an issue that I deal with daily, de-escalating agitated patients in an emergency setting. To provide some perspective on the issue, most patients who enter the hospital do so via the emergency department, ED. Many won't have received medical treatment yet, and that can make it more likely for these patients to become agitated. This can be exacerbated by their medical condition, a psychiatric illness, or other stress factors. Given the chaotic and crowded nature of the ED, it's imperative that we identify agitated patients early and apply non-physical de-escalation techniques as soon as possible. The provider who is going to initiate the de-escalation process should make sure that they create a considerable amount of space between themselves and the patient, and make sure that no one else is closer to the patient than they are. This not only gives the patient space, but also keeps the provider safe in the event of attempted physical violence. Ideally, both the patient and provider should also be able to leave the area without the other blocking their exit. Body language and tone of voice convey overall emotional state to a patient, so providers should remain outwardly calm throughout the encounter. When speaking to the patient, you should start by introducing your name and role in the team. You should determine how the patient prefers to be addressed, and err on the side of being respectful. Use short sentences and simple vocabulary to enhance understanding. Leave a suitable amount of time between statements to allow patients to process what is being said. Sometimes repetition and enunciation may be necessary. Eye contact should be intermittent, so the patient does not think you're staring, and verbal responses should be calm without any hint of insults or challenges. Only one provider should interact with the patient, as multiple speakers can confuse an agitated patient. When the patient speaks, it's important to identify what their wants and feelings are, even if they may be impossible to address at this time. Try to consider things from the patient's perspective. Although they may be suffering under a particular delusion, such as paranoia, try to understand how the patient might feel or react if that delusion happened to be true. While we do not want to endorse these delusions, it's important to find common ground. For instance, if the patient is agitated because they think they are being followed, the provider can agree with the general principle, saying something like, "I understand that your suspicion of other people can make it hard to get the treatment you need here." It is also okay for a provider to agree that while they may not be having the same experience as a patient with an obvious delusion, they can believe the patient is having that experience and reacting to it. In addition, patients should be encouraged to make choices in order to give them a sense of control over the current situation and diffuse their overall aggressiveness. These choices should be realistic, however, and deliverable, as unfulfilled promises may backfire and irreparably damage the therapeutic alliance. Some of these choices can include medications to help calm the patient. A good way to state this is, it's important for you to stay calm so we can talk. Can we provide you with some medication to help you feel less anxious? Offering patients a choice between different medications or routes of delivery may also provide a feeling of control to the patient. Lastly, when the crisis is over, a key technique is debriefing both the patients and staff on how the situation went. The patient, now calm, may be able to provide more insights on what they were thinking and how they were feeling at the time. The provider can discuss coping skills or alternative options in order to prevent another aggressive incident in the future. It is also important to talk to staff as well, to gain any third-party feedback on the provider-patient interaction, what was appropriate, what helped de-escalate the patient, and any other changes that could be made to ensure patient, staff, and bystander safety. These techniques can be applicable to a wide variety of patients in numerous settings. They're not just restricted to the emergency department. Our hope is that providers will be able to de-escalate patients safely and effectively without having to resort to the use of physical or chemical restraints. which should be considered only when all other approaches have failed.